Howdy everyone, my name is Richa Candy and I am a sophomore public health student here at Texas A&M. I'm really excited to share my study today on can telehealth use impact self-efficacy in managing health and self-reported health among older adults, a structural equation modeling study. Telehealth is a great tool that can be used to mitigate the effects of distance and improve access to healthcare. We saw during COVID-19 that it was really helpful in delivering healthcare, in particular to older adults who are more susceptible to the virus. Telehealth is a great tool for older adults who often face mobility issues and need transportation. However, some of the challenges of using telehealth is that senior citizens can have difficulty navigating the platform, lack of familiarity with using the devices, as well as reduced interpersonal interactions that might affect their confidence in managing their health. Based on previous literature, we saw self-rated health is a powerful predictor of overall health and has been shown to possibly influence by self-efficacy. Self-efficacy is an individual's confidence to take care of their own health. Telehealth platforms can enhance a person's self-efficacy by providing clear communication and more user-friendly interfaces, which is more likely to improve health outcomes in older adults. However, there's not many findings that we saw in the context of older adults, so our study aims to look at can telehealth improve their confidence in managing their health, and does this confidence translate into better health outcomes? So the study really looks at the pathway between telehealth use and self-rated general health in adults, both directly and via self-efficacy, which serves as our mediator. We used data from HINTS from cycle 6 from May to November 2022, and our sample was around 2,203 participants, 65 years old and older. We used structural equation modeling to look at the pathway and the role of self-efficacy in mediating between telehealth use and self-rated general health. And our model was based off of existing literature. Looking at our results, we see in table 1 that we had a good goodness of fit for our full-scale structural model as seen with our observed data. Table 2 presents all our direct and indirect pathways. Our findings indicate that they're all statistically significant. However, we do see negative associations of telehealth use with self-efficacy and self-rated general health. Self-efficacy was positively linked with self-rated general health, as seen with previous literature. Moving on to our discussion, we see there was a negative relationship between telehealth use and self-efficacy and self-rated health, which could probably be from older adults' difficulty with using this technology, as well as perceived lower quality of care in comparison to in person. Older adults could also have more mistrust and privacy concerns, which could further contribute to that. Telehealth use indirectly impacts self-rated health. There is a negative effect on self-efficacy, which is our mediator, suggesting that the decline in self-efficacy due to challenges with telehealth leads to lower self-rated health. There could also be cognitive challenges with using telehealth, which could further lower self-confidence and also self-rated health. Looking at our implications, we see telehealth platforms should probably simplify and make it more user-friendly for older adults, like larger text, voice-assisted navigation, and tutorials. Healthcare providers could also offer training to help older adults be more comfortable with using it and thereby increase their self-efficacy. Telehealth services should also be more personalized, possibly by using virtual communication quality and ensuring that older adults feel still supported even without in-person visits. Future programs can also target interventions, and policymakers could also focus on reducing digital inequities, ensuring that older adults have the access to affordable devices and internet to use the services. We could also use more easy to use technology, improved clear communication and support to improve self-efficacy. And we could also ensure that healthcare providers should adapt to more communication styles that are still translated through telehealth. Some of our limitations of this study is that we used HINTS data, which limits their ability to look at causality. And we also relied on self-reported measures, which could be a cause to recall bias or subjective interpretation of measures' health status. Something that we plan on looking at later on is the absence of is to stratify by demographic factors like age, gender, and socioeconomic status to further understand the relationship between telehealth use, self-efficacy, and self-reported health among different populations. Thank you.